Again, I'll just repeat some of those housekeeping announcements. Please go ahead and post your questions to the chat. We've got some folks that are going to sort those into some themes and present me with some questions at the end of the webinar. But go ahead and put the questions in the chat as they occur to you. Within about a week, you'll get a package of resources and tools, including all of the slides that I'm going to share today, and you'll have access to a video recording of today's webinar. Throughout my presentation, I'm going to put up some interactive Slidos, so you'll have your phone ready to snap the QR codes, or you can open a separate tab in your web browser and type in the URL to respond to the questions that way. And so Dr. Laura Papard and Megan Erickson are here with us as well from ADAPT, and they'll be helping to monitor the chat and to capture your questions, which we'll try to answer, as I said, at the end of the webinar. So as was mentioned, I'm Associate Director for Implementation Science and Strategy at ADAPT, where our mission is to support the integration of the best available evidence for substance use prevention into communities by advancing mindsets, knowledge, and skills. And I see we have a lot of participants joining us today, and that's great. And thank you for taking some time in your busy work week to explore these topics with us. And just to help me get a sense of where you're all at in your own professional journeys as a prevention professional, can you pull up this Slido and let me know how long you've been working in the field? Give you about 30 seconds to pull that up and respond. People can. Some input. I see some people are just putting it into the chat. That's fine too. There will be some more Slido questions, so you can pull up hit that QR code. It'll just forward on its own to the next question. Great. Well, we've got a fantastic mix here. Certainly, it leans to folks that are just beginning their journey in prevention work. And I'm confident that no matter where you are, you'll in your journey, you'll come away with some new knowledge or new perspectives on prevention that will be helpful in your own work. So these are the learning objectives for today's webinar. We're going to review the principles of effective prevention practice grounded in prevention science and talk about common characteristics of effective and ineffective prevention strategies. We'll examine the role, the value, and the limitations of research evidence, contextual evidence, and experiential evidence in selecting, refining, or de-implementing prevention strategies. We'll evaluate the evidence, fit, and feasibility of prevention practices, programs, and policies using one or more online evidence registries. We'll talk about online registries. And I want you to come away understanding the important factors beyond research evidence that impact the effectiveness of prevention strategies. So ADAPT's model for training and technical assistance recognizes that that knowledge and skill building is a process. And so my goal today is just to give you a good foundational understanding of these concepts. But this is just a glimpse, and I encourage you in your professional development to, beyond what we talk about today, to really immerse yourself more deeply in each of these concepts and work toward developing your competence in these key topics of the prevention profession. And obviously, the Southeast PTTC and ADAPT can offer lots of resources to support you in developing those competencies. So my presentation today builds on 5 key messages. And my first message is that the way we think about prevention shapes our approach to prevention, which drives our ability to achieve prevention. So we know a lot. Youth drug use is one of the most studied areas of adolescent development and well-being. And there's no shortage of opinions, and thankfully no shortage of passion for this shared goal of preventing youth drug use. But beyond our passion and our good intentions, it's important to recognize that this is a profession grounded in science. And we want to show that in how we think about and how we approach the work. We need to know and believe that prevention works when it's informed by prevention science. So let's define that. Prevention science refers to the study of the determinants of individual, family, community, and societal level problems with the goal to develop science-based prevention practices, interventions, and policies that reduce the incidence of harmful conditions and promote the processes and conditions, that enhance health and safety. So we've learned a lot from the way we've used science to drastically reduce mortality from health problems such as lung cancer and heart disease in this country. You all, I'm sure, can tell me, even though you're not cardiologists or oncologists, you're not heart doctors or cancer doctors, but yet you know the things that increase your risk for cancer or cardiovascular disease, right? You don't smoke, you exercise, you eat a healthy diet, and you try to manage your stress. And even when you don't do these things, you at least feel guilty about it because you know you're putting yourself at risk. So prevention science grew specifically out of an intentional effort to replicate that approach with other health outcomes, including adolescent drug use. And now, 50 years later, we know a lot. And my friend Bill Nye, the science guy, agrees. This is science. This is prevention science. And so let me take you on a very quick tour of some of what we've learned from 50 years of rigorous prevention science. Now, this is a bit of a grab bag, but remember, these aren't hunches. These prevention principles that I'm going to go through here for the next few minutes, they're not hunches. Everything I'm about to rattle off is grounded in a half century of rigorous science. And so, first of all, risk and protective factors are the mechanism for prevention. So the very first question you want to be asking when faced with any decision about adopting or considering a prevention strategy is, what risk and protective factors does this strategy address and why? Secondly, each community has its own unique profile of needs. So risk and protective factors, every community in this country is concerned about the outcomes of youth drug use and other adolescent behavioral problems that we're trying to reduce and prevent. Even though every community is concerned about the same problems, the profile of risk and protective factors that drives those problems is going to be different in each community. So each community has its own unique profile of needs. Third, we should start as early as possible. Upstream prevention is the most impactful way to do prevention. We should be constantly thinking about how we can get upstream and get even earlier in our prevention. We should focus prevention work in families and in schools and communities. And each of these contexts has its own specific mechanisms that drive the impact and the effectiveness of prevention in those contexts. Likewise, in middle and high school, in addition to elementary school, there are specific risk and protective mechanisms that we want to focus on. We want to think about key transitions that apply to the whole population. I'll talk a little bit. And then we want to combine multiple strategies to amplify the effects of our prevention efforts. Across these multiple settings of families, communities, schools, we want to make sure that our prevention efforts are coordinated and consistent. We need to be realistic about the dosage and duration necessary to affect behavior change in young people. You can't just be hitting them with information about, what are the negative health consequences, what are the negative legal consequences. Really trying to teach skills that are behavior change. That requires a certain level of dosage and duration of intervention. And we need to employ interactive techniques and rehearsal with kids for them to really learn and practice those skills. Next, when we select an evidence-based strategy, but we decide that we need to adapt that strategy to meet the specific needs of our communities, it's really important to retain the core elements responsible for that strategy's effectiveness. And finally, we know absolutely that evidence-based prevention programs are incredibly cost-effective, especially in comparison to other options. Now, again, I could list multiple citations in peer-reviewed scientific journal articles for each of these things that I've listed. And this isn't an exhaustive list, but it's meant to illustrate that we have a deep, deep science to inform our understanding of how problems develop and how we should intervene. And we should look to that science to inform our approach to prevention, because that will directly impact our ability to actually achieve our prevention. So based on all of this science and based on these prevention principles, many preventive interventions have been developed and tested in rigorous evaluations. From that cumulative body of knowledge about prevention strategies, we also have a core of evidence about generally some types of prevention approaches that have been found to be effective. And we can connect these effective approaches generally back to those established prevention principles that I just mentioned. So when we're thinking about intervening directly with youth, just one type of strategy, again, we need to have those youth practice skills, those skills, decision-making, problem-solving, assertive communication. These are mechanisms that have been found to be important in the way youth substance use develops and in intervening to prevent that outcome. And so that's the mechanism of change that we need to be thinking about interventions that work directly with young people. Interventions likewise that target parents or teachers or other adults. We want to think about the mechanisms of monitoring, parental monitoring, role modeling of parents and adults, setting clear rules, and all of these interventions that are based on adults, trusted adults working with young people, they're grounded in relationships. So health promoting relationships are a fundamentally important mechanism for doing prevention that involves relationships between adults. And then likewise, interventions that target communities and school and society. We want to think about interventions that increase a sense of school connectedness, because that's one of the risk factors that puts kids on a trajectory towards substance use in adolescence, is becoming disconnected from school and the school process. We want to think about changing youth and community norms as a potential mechanism. We want to think about enacting laws and policies that limit access to substances, and counter advertising approaches that are based on effective prevention communication strategies. I've seen so many communities and entire states that invest millions of dollars in ad campaigns that really are disconnected from what the evidence shows works in terms of effective prevention communication strategies. Now, likewise, there are some.
Ryan?
Yeah.
Sorry to interrupt you. Just real quick, we were having some issues hearing your audio in chat. A couple people have mentioned it. I know we had adjusted it early on in the tech check, so maybe you could turn up your microphone volume again. I think that helped last time.
Is it too quiet?
Yeah, it's too quiet and it's a little staticky.
Okay. I will, I'll try to speak louder. Not actually able to access my audio control while I have the slide deck sharing, unfortunately.
Okay.
And you might be, I think, and I'll try to be more, so I'll try to project and speak more loudly. Is that a little better? Can you hear me okay?
I can hear you okay. I think maybe we can hear from the folks in
And
chat.
some of this data may be buttons on my jacket rubbing on the edge of my desk. So I'll try to be more conscientious about that. Okay, so likewise, there are some approaches that we know just don't work, but they keep hanging around. So as prevention professionals, you will be faced with people who want to suggest and recommend some of these strategies. And it's important to understand that we know that there are some specific strategies that just are ineffective. And so when we say these don't work, we mean that years or decades of attempting these strategies have consistently failed to produce any credible, lasting evidence that these strategies actually increase adolescent drug use. And that's another fundamental tenet of prevention science that we should never forget, the Hippocratic Oath, that first, do no harm. We need to make sure that even when we're driven by our enthusiasm to promote better outcomes for young people and to prevent youth drug use, that sometimes, even with the best of intentions, we can actually cause harm. So I would say that if it's cheap and easy, it probably doesn't work. So think about physical health and all the fads versus what's really effective in promoting our own physical health. And it's hard work, right, to promote our own physical health. Likewise, it's difficult. It's challenging and complex to really use prevention science to promote better outcomes for young people. So I would encourage you to be skeptical of the silver bullet or the quick fix, and to remember that we have very limited resources and energy, and we need to be thoughtful and strategic to get the most bang for our buck, and to make sure that we're doing no harm. Now, there are a number of frameworks that help guide our thinking about how to do prevention work effectively. And one of these is the Institute of Medicine's continuum that reminds us that our prevention efforts are embedded alongside other strategies all throughout this continuum. And we need a mix of approaches. We can't ignore any one of these segments, but the prevention segment of this continuum is really important. And something called the prevention paradox tells us that we can't just focus our prevention efforts on a small number of young people that we think are at risk or high risk. It's really most effective to invest a larger portion of our prevention efforts on universal prevention, because we can't accurately, thinking about this idea that I mentioned earlier, think of going upstream as far as possible, even prenatally. We can't accurately differentiate early enough on the developmental trajectory to choose who is actually at risk. And I'll explain a little bit more. I'll explain that a little more in depth shortly. I also want to recognize the importance of health promotion as a key partner to prevention. If you're in this prevention business, you will come to realize that the absence of bad outcomes is not the same as flourishing or thriving. And that we can do better than just helping kids survive adolescence without overdosing or dropping out of school or ending up in the juvenile justice or child welfare system. That's not the same as thriving or flourishing. And so we should endeavor to set our sights higher for all young people and all families and all communities. So one of the points that you may have picked up in my quick tour through the prevention principles is this idea of important developmental stages. There are specific risks and protections at each stage of a child's development. And risk and protection are cascading and cumulative. So as children age and develop, they bring along with them the baggage, good or bad, of the previous developmental stage. So one implication of that is that the longer we wait, the bigger our challenge. It's common to focus our attention at the point at which we see problem behaviors emerging, but the stage was set for those problem behaviors long before we see them. And we know there are certain periods and certain events when risk increases or protection is especially needed. In particular, the transition into preschool or kindergarten, the transition from elementary to middle school or to junior high, and the transition out of high school into pre-adulthood. These are all times of elevated risk. And likewise, events like a divorce or an important challenge of an older sibling or the death of a family member, these are critical milestones we should be ready to help youth navigate. So these are all particularly important points to provide kids and families with extra support. And all of these things have important implications for when and where we place our preventive interventions. Another mental model for prevention practitioners that I've always found helpful is to recognize that every child we encounter is at a point along a developmental pathway. And a lot of effective prevention is about changing the trajectory that kids are on for the better. Again, we can't inoculate children or adolescents against risk. It's a continuous, ongoing process of keeping them on the healthiest developmental trajectory, considering where they are right now, what baggage of risk they brought with them from the prior developmental stage, and thinking about how we can intervene where they are right now and where they're headed. So I mentioned 50 years of prevention science, and I offered that analogy of the fact that we know the risk and protective factors for heart disease and lung cancer, for example. So this picture on the left, it's one of the most impactful things that I've seen in all of my professional career working in the prevention field. It really lands for me as a visual representation of prevention science, and it conveys a lot in this matrix. So think about those risk and protective factors that I mentioned that we all just intuitively know. Don't smoke, exercise, eat healthy, manage our stress. A lot of researchers spent a lot of time studying populations of kids that experience problematic adolescent health outcomes. And they looked at the things that those kids had in common and what differentiated them from kids who didn't experience those poor outcomes. And across many studies, cumulatively involving hundreds of thousands of kids, this generated a specific list of known risk and protective factors that are statistically associated with a higher likelihood of poor outcomes. Now, two things I want to call your attention to in this figure that are fundamentally important for us to remember in our prevention. First, risk factors are shared across multiple behavioral outcomes. So if you look at any of those risk factors listed on the left side of that matrix, and you follow that across to the the six adolescent problem behaviors that are listed in the columns to the right, you can see that many of these risk factors predispose kids or increase the likelihood that kids are going to experience more than one of these adolescent problem behaviors. And that's really going to be fundamentally important in the way we approach our prevention. The second thing to notice about this, if you look at the gray bars that are above the individual risk factors, risk occurs across multiple ecological domains. So we have risk presenting itself, and likewise, we can offer protection in the community, in the family, in the school, and in the individual child or their peer group. And those things are constantly coming in and out of a child's life, affecting their developmental trajectory. And that's important to keep in mind because there's sort of a natural tendency to think about a prevention program or a prevention strategy that's based in the community or that focuses on family strengthening or that is a school-based intervention. But keep in mind that one intervention in that one domain is probably working against things in those other domains that we may not be addressing and that may be undermining what we're trying to do in that one domain. So now we're getting to a fundamental understanding of how youth substance use develops, and we see the complexity of it and all of the influences, positive and negative, across a child's development. And, we're left with one overwhelming conclusion. It's complicated, right? So, and I kid, my point is not to overwhelm you with the complexity of all this, but just to remind us that this is a meaningful task and that there are no quick fixes. We need to be really grounded in the science, be thoughtful in our approach and decisions, and be committed to developing a sound, strategic, comprehensive approach to prevention. So that's my second message, to ground preventive interventions in a broader, comprehensive strategy. And that brings us to this idea, which is the title of this webinar, of evidence-based practice. And so I'm going to go deep in the weeds on evidence-based programs in a little bit, because that's one of the things that I was asked to talk about in this webinar. And that's something that a lot of prevention practitioners really want to learn more about. What is this idea of evidence-based programs? What does it mean? What value, what do they restrict my choices? But before I go into the weeds about evidence-based programs, I want to differentiate evidence-based programs from this broader idea of evidence-based practice, which is a systematic approach that integrates the best available research evidence with contextual and experiential evidence to make informed decisions, translate evidence into practice and policy, monitor fidelity of the things that we're implementing, the strategies that we're implementing, and evaluate and then hopefully sustain the interventions that we find to be effective. This evidence-based prevention practice as a systematic approach, this is what has been shown to move the needle on key behavioral outcomes at the population level. And the specific programs or strategies only explain a portion of those outcomes. The programs or strategies within this broader systematic approach, they're synergistically connected and they amplify the impact of our programs and strategies. And again, the goal of today's webinar is really exposure to a lot of important ideas. And this is one, this idea of comprehensive strategic prevention planning. And I just want to call your attention to a toolkit that ADAPT has developed. And this will be in the resource supplement that I'll be sending out next week. But I wanted to just lift this up as sort of a guidebook, a toolkit to think about these five phases of an approach to comprehensive strategic prevention planning. And we focus a lot of our attention on the decisions around which programs or strategies or policies we want to adopt, but that comes at stage 3 and 4. And there are important aspects of prevention planning that have to come before our decisions about which strategies to adopt, and that come after we decide which strategies to adopt and implement. And so if we know that these risk and protective factors are key to effective prevention, and that they exist in all these domains, and that we need a strategically selected set of strategies, how do we know what we need? And that's really, in my experience, that's the fundamental question. How do we know what our specific community needs? And effective prevention is absolutely reliant on a solid assessment of needs and resources and readiness, because so much of prevention work comes from a place of passion and commitment. It's natural, like I said, to want to jump straight to the stage of choosing and implementing strategies. We want to get to the action. We want to get to what are we going to do. But that's like going to the pharmacy before you've gone to the doctor, right? And so I want to, what I'm showing here on this slide is a resource guide that the Prevention Research Center at Penn State University recently put out, where they did an assessment of the different types of, or they did a synthesis rather, of the different types of youth risk and needs assessments that exist across all the states in this country. And they found a lot of variability. And again, this is going to be in your resource supplement. And I encourage you to, whatever state you're from, go into this guide, look at the different risk assessment tools, look at what your state uses, what aspects it does or doesn't collect information. So, so this, in my opinion and experience, this is the most underappreciated and overlooked mechanism for doing really impactful prevention. And I encourage you all to ask hard questions about the quality of your assessment tools and process wherever you're trying to do prevention. I recently just got a new primary care physician, and I went to visit that primary care physician for the first time just to establish him as my doctor. And the very first thing he did, before he asked me anything, before he even knew why I was coming there, the first thing he did was to order a full panel of blood tests. And just like the test your doctor runs to diagnose the cause of your symptoms, that then informs his or her recommendations, a high quality diagnostic needs assessment process repeated every couple of years is fundamentally important to driving our prevention. It helps to guide us strategically towards solutions, and it begins to articulate a logic model for how we think we'll actually achieve our prevention goals. And our data, the data that we collect in our risk assessment process for like a community or a school, that data needs to be fine-grained enough to help us differentiate between different programs, even different evidence-based strategies. Right? So, I'm sure that you've, like me, you've gone to the grocery store to pick up some cough medicine. You walk down the aisle, and then you stand there staring at all the different types of Robitussin cough medicine, right? So these are all evidence-based, right? They've been found to be effective in reducing cough. But you need to know kind of what's going on with that cough. Where's it coming from? Because these different types of evidence-based cough medicines, they have different medicines within them that address different underlying causal symptoms that are driving your cough. And so, I think that's a good metaphor for me. It's like, even, you need to understand what the underlying causal mechanism is. Antibiotics, for example, are effective for bacterial pneumonia, but not for viral pneumonia. So you need to know, if you had pneumonia, you need to know what kind of pneumonia you have to know which medicine is going to be effective, even among different evidence-based medicines. So without a really strong community diagnostic profile, we're really often left just guessing what will promote better outcomes in the kids and communities. So this idea of a strong diagnostic profile, there's as much power here as there is in evidence-based programs, and we need both. We need both of those things because they inform and reinforce each other. So if you allow me to mix my metaphors here, we need a complete toolbox with all the right tools for the task at hand. What we're doing in strategic, comprehensive prevention planning is we're putting together a puzzle, and every piece of that puzzle is vital. Have you ever put together a jigsaw puzzle and you get down to the very end and you realize that you've run out of pieces and the puzzle isn't complete yet? Somewhere you lost a few puzzle pieces, and the puzzle is just not complete yet. Okay? So it's important to think about how all those puzzle pieces fit together when we're thinking about our public systems, for example, separate outcomes into silos. But as I said, these outcomes are predicted by shared risk and protective factors in individuals and families and schools and communities. And so if we have this well-designed diagnostic profile of what's driving those problems in our communities based on what is the profile underlying risk and protective factors in different domains, collectively these community profiles can promote coordination and collective impact locally and inform both local and state level priorities. I don't know if there's any state level folks on the call today, but you can think about applying this idea of a community diagnostic profile at the community level. But if every community in a state is doing a community diagnostic profile, the state could assemble all of those into a state diagnostic profile and say, okay, here are some priorities that are coming up in a lot of individual communities, and we as a state, it would be strategic for us as a state to invest in those priorities because they're found in a lot. They're not unique to a small number of communities. They're found in a lot of communities. So that's just a side note, that an additional value of these community diagnostic profiles. So my third message is about selecting strategies based on the best available evidence. And so remember that we want to thoughtfully select or design preventive interventions using the best available evidence to prevent unintended consequences. And those unintended consequences could go all the way from we wasted time and resources on something that wasn't a good fit or wasn't effective to we actually made things worse for kids. And that's how I encourage you to think about evidence. So let me stop and throw up another poll question here. How confident are you in using the best available evidence to select a prevention strategy? How confident are you? And again, I'll give you a little time to respond to that. I know there's a lot of people. I hope there's a lot of people still on the call. I can't see the numbers. And I hope I'm seeing every once in a while, I'm seeing some comments about having trouble. So some people, it seems to be different for different people, but some people seem to still be having trouble hearing me. So I'm going to just try to remember to speak up, speak loudly, and hopefully that it doesn't become too much of a problem. So folks are pretty confident. We've got about 60 people that have responded to this poll question. And folks feel pretty confident about their ability to select the best, to use the best available evidence in selecting prevention strategy. And that's good. That's good. So we're going to dig down into that idea of evidence and what that means. So, if you work in prevention, you can't escape this idea and this terminology around evidence-based. So it's really important, I think, for the field to have a baseline understanding, to make sure that we're all talking about the same thing when we use that term evidence-based, and that we understand both the value of evidence and the limitations. So Webster's definition of evidence is that which elucidates and enables the mind to see truth. Proof arising from our own perceptions or from the testimony of others or from inductions of reason. So evidence is a collection of indicators that illuminate our path to the truth. I love this picture of the lights along a dark pathway. That's the way I see evidence. It gives us confidence in the darkness that we're moving in the right direction. In a legal system, in court, there's rarely a single piece of evidence, no matter how convincing, that is sufficient to establish the truth, guilt or innocence. Likewise, evidence of effectiveness of prevention programs is strongest when it draws from multiple sources. And again, like, when you go into the pharmacy, everything in the pharmacy is evidence-based. And that evidence, think about where that evidence came from that allows some things to be sold in a pharmacy and some things to even be behind the counter and only accessible through the pharmacist and prescription. Let me stop for a second. How big is the problem with my volume? Is it becoming a distraction? Should I stop and try to, Olivia, do you have an opinion about whether it's interfering or becoming a distraction?
Why don't you stop sharing real quick and see if there's something you can do? Maybe switch. It seems like it's really like dependent on, some people are saying it's fine. It might just be slow internet. It's muffled a little, but I'm still able to follow. I can hear you. It sounds fine to me. So maybe if there's something you can do, maybe a different microphone or is there a way to turn up your audio volume, like within your microphone settings? It could be something like that.
Okay, so I have turned up my microphone volume all the way. Is that any difference at all? Weird. Some people can hear me just fine. So yeah, I'm not exactly sure, but hopefully it's not so many people.
Okay, Tanya said it sounds better, and I know she was having issues earlier, so that's good. Yeah, maybe just like projecting as loud as you possibly can.
Okay, great. So
Thanks for fixing that. I appreciate it. Yeah, a couple people are saying it sounds better, and that it might be a connection, device connection issue. Thank you, Brian.
Okay, I'm sharing the right screen again, I hope.
Yes, you are.
All right, so I'm going to give, on this idea of evidence, I don't mean to teach a graduate level course. This is just exposure, but I think it's really important to understand what a randomized controlled trial is, because that is considered the gold standard of program evaluations, and it often is it's the first consideration for determining whether a prevention program gets labeled as evidence-based and ends up on one of the evidence-based program registries that I'm going to talk about in a little bit. So I just want to give a real quick overview, because when I entered the prevention field after an entire career in juvenile justice and criminal justice policymaking, I didn't have any idea what a randomized controlled trial was. I did not know, and I had to read all these journal articles and kind of determine what's effective practice. And I was embarrassed to tell anybody that I didn't know what a randomized controlled trial was. So I just want to make sure that people have sort of a baseline understanding of sort of what this is, this gold standard program evaluation. So if I evaluate my program and find I got good outcomes, can I call my program evidence-based? And that's usually not sufficient to have a program land on a registry or list of evidence-based programs. So this is the typical way that we evaluate our programs. We have a bunch of kids, we give them a pre-test, we offer them a prevention program, we give them a post-test, we see if the things we measured in the pre and post-test change in the direction that we want them to change. So we can compare the difference between pre-test and post-test. But what if something else caused the change? What if the post-test isn't better? Does that mean the program didn't work? What would have happened in the absence of the program? Maybe the kids were already trending in the direction that we picked up in the post-test, and that change maybe would have happened anyway. And are these kids that we're measuring, are they representative of all kids? So if we do a pre-test and post-test, we have a good sense of what's going on with those kids, but we don't know if it will be this, if we would find the same result if we ran that program somewhere else in a community that doesn't look like our community. So the idea of a randomized controlled trial is specifically designed to address some of those buts. It's meant to rule out alternative hypotheses for the outcomes that we find, so that we can more confidently attribute our outcomes to the program or intervention that we're testing. So we take a bunch of kids, we randomly select them to be divided into two different groups, and that random selection into these two groups is really important, because by randomly assigning them, we're saying that, well, if there's something else that might be explaining the difference between pre-test and post-test, that something else is equally likely to occur in both the treatment group and the comparison group. So it sort of rules out the idea of something else explained what we're finding, right? And so again, this is a gross oversimplification of a topic that takes entire graduate level courses, but hopefully you'll see the point, and it will help you appreciate the idea of research evidence, the added value that a well-designed evaluation study adds in terms of being able to attribute program outcomes to the specific intervention or prevention program or strategy that we're testing. And so when we think about this idea of evidence-based programs in particular, different from evidence-based practice, the larger systematic approach, evidence-based programs, I would say they're theoretically sound interventions that have been evaluated using well-designed study, a randomized controlled trial or other strong design, and they've demonstrated significant improvements in the targeted outcomes. Now, beyond that, evidence is strengthened even further if there's independent replication. If different researchers studied the same program and got similar effects, and if the researchers measure that those effects are not only present right at immediate post-test, but they reassess those outcomes 6 months later, or a year later, or 5 years later, or sometimes 20 years later into adulthood. So if we have sustained effects, that's even more evidence and confidence that we have that, yes, it was that intervention, that prevention strategy was responsible for changing those outcomes. And so these kind of programs, these programs that meet that high standard, they give the greatest confidence that they could be effective at promoting better youth outcomes if they're a good fit and they're implemented well. So again, the evidence that comes from well-designed research studies, evaluation, randomized controlled trials, that evidence is really establishing whether a particular strategy could be effective. And that alone is really, really valuable. But again, we have more to think about. We'll get to that. So, this figure at ADAPT, we really rely on this figure from the Centers for Disease Control to think about understanding evidence, think about a continuum of evidence of effectiveness. And it really captures, again, like that risk factors picture that I shared, this graphic really captures a lot. And I want to walk us through this for just a few minutes. and point out some key parts. So I really encourage you, beyond what I can cover in this webinar today, we're going to send you out this figure. It's going to be in the resource supplement that I send out. And I really encourage you to spend some time with this figure and understand all that it conveys. Honestly, if you're a prevention practitioner, print this out and hang it up in your cubicle, because this should be a handy reference to think about what evidence means and what is the value and what are the limitations. So the first thing I want to point out is the word continuum. The continuum tells us that there are different degrees of evidence, right? This is a really important point because people fall into the trap in discussions about evidence-based prevention. People fall into the trap of considering evidence of effectiveness as either present or absent, yes or no. If it's not evidence-based, it's ineffective. If it is evidence-based, it's guaranteed. And neither of those is absolutely true. This is about establishing a level of confidence. And think about evidence along this continuum. But as you can see, there are other places besides effective or ineffective where a program could land, right? Those are the extremes. And, at the top, we're asking some specific questions about the quote unquote proof, about the evaluation research that is establishing the research evidence, these randomized controlled trials, for example, that I talked about. We start by asking whether in the evaluation of the program, the targeted outcome changed. And note that it could have changed for better or for worse. Then we need to establish whether or not the change we see in the targeted outcome can be reasonably attributed to the program, like I said, versus something else. And this is why randomized controlled trials are the gold standard. And when there are multiple studies of a program, we consider them collectively. And the highest standard, like I said, is independent replication. Different researchers coming to the same conclusion about this strategy's effectiveness, even if especially if they were studied in different populations. So you can see that if a program meets these criteria at the well-supported end, that's a really strong collection of evidence that the program is in fact effective, and the prosecution rested case and the sun has come up on our dark path. We have a way that's lighting our path that lets us see the direction we should be considering. So that's a lot, right? So I want to talk a little bit about evidence-based program registries and how we make use of them as a tool. So if you could bring up this next Slido question and tell me, have you searched for a program on a registry of evidence-based programs? Okay. Right. So it looks like more than half of you have never searched a program, an EVP registry, or you've done it maybe one registry one or more times in the past year. So some of you don't have any experience with this at all, and some people have some experience. So that's good. That's helpful for me to know, because I want to talk a little bit about how all of this information about evidence is kind of collected and synthesized, made available to you as prevention professionals and to communities and schools, people that are interested in doing good prevention work and getting better outcomes for kids and families and communities as a tool. Another tool in your toolbox, another puzzle piece in your puzzle. So of those things that I talked about in that Centers for Disease Control picture of understanding evidence. That's a lot to consider about the evidence of any program or strategy. And I'll be honest, over the course of my 30 years in prevention, we've literally gone from not knowing any prevention programs with good evidence of effectiveness to having so many programs, strategies, and environmental approaches with good evidence of potential effectiveness that we've had to actually develop searchable registries to not only find the things that quote unquote work, but to choose among them, to sort among a lot of different evidence-based strategies. And interestingly, I put this picture of this Bridgespan report up. There's even a growing evidence base now about how to use the evidence base. So it's called utilizing the what works marketplace. Like how do we, people are studying, how do we sort through all of this information? And so, sorry, I jumped that cover again. So these are really important developments in our field that now we have a collection of many, many strategies that have been evaluated in well-designed studies and found to have evidence of effectiveness. And these registries can be valuable tools in our toolbox. And just like I said, you know, hang that picture of that understanding evidence continuum in your cubicle as a ready desk reference in your prevention work. I really encourage you to familiarize yourself with all of these registries, and I'm going to send out even more information on more registries in the resource supplement that I'm going to send out next week. So I really encourage you to familiarize yourself with these different registries. Just, it doesn't, you know, it's not rocket science. You go onto these registries, there are some search criteria that you can put in there. You can search on different aspects of programs. You can look for programs that are school-based versus community-based. You can look for programs that target specific risk factors. You can look for programs or strategies that are environmental strategies versus programs that work directly with young people and behavior change. They can be strategies addressing laws or availability, etc. So, and you might rely on you'll see that these different registries, they have different strengths and they have different search variables, and they generate different output, honestly, because they might be focused on different outcomes or different contexts. So for instance, there are a couple of registries that have been developed by the US Department of Justice. And so their focus is really more on, well, what prevention strategies are most effective in keeping people out of the criminal justice system or the juvenile justice. There are registries like the IES, that's the Institute for Educational Sciences, What Works Clearinghouse. They're more focused on outcomes that are related to academic achievement and performance and school connectedness and graduation. But again, keep in mind what I said earlier, because all of these problems grow from a set of shared risk and protected factors, the programs that end up being effective are almost always addressing those underlying risk factors. So they might be, so a program that's effective in promoting school connectedness is probably also going to be effective in reducing and preventing adolescent drug use. So, you know, I want to encourage you to just spend some time on these directories, these registries, and just see what you like about different ones. And honestly, you might rely on different sources or different EVP registries in different situations based on the need and context. That's the place that I've landed. I don't rely, there's one registry that I rely on primarily, but I never stop at just that one registry. I go to a few different registries and say, okay, do they kind of confirm what I'm finding on this one registry based on what I'm looking at? Again, I'm going to send you out information and links to a bunch of different registries that I encourage you to check out. And some states have really leaned into, individual states have really leaned into this idea of promoting and supporting the use of evidence-based strategies. And so Washington State has developed this Athena Forum, which is one specific registry, but I wanted to lift this one up in particular because it includes not only a searchable registry of programs, but a catalog of other tools to support the professionalization of their prevention workforce. And you'll notice that on this Athena registry, they include a lot of environmental and policy strategy, which don't show up in many of the other registries. A lot of the registries focus specifically on programs, like child or family focused interventions, rather than environmental strategies or policy strategies. So I think this Athena Forum is really, really valuable in that sense. And Washington State has a significant Native and First Nations population. So they have a whole collection of resources dedicated to tribal prevention and wellness. And that's another thing to consider when considering the evidence is, cultural fit and contextual fit to a specific population or community. So I just wanted to be sure to call attention to that site in particular. And then this, SAMHSA Evidence-Based Practices Resource Center, although SAMHSA no longer has a searchable EBP registry that they used to have, they still do maintain this resource center that contains a lot of really helpful resources. And I'll share a number of those resources again in that supplement that I'm going to send out next week. Now, obviously, federal resources and websites are fluid right now, but I think this website is still available even as SAMHSA is currently in transition. So just something to consider. And I mentioned the register. I mentioned that there's one registry that I primarily go to as my first source, and that is what's called the Blueprints for Healthy Youth Development. And I have found that this registry fits my needs most often. And one of the things that I like about the Blueprints for Healthy Youth Development registry is, once you put in your different search strategy, your search criteria, and you generate, a list of a few evidence-based prevention strategies that you want to consider and compare, you can generate a fact sheet that includes not only a lot of information about the research evidence and the studies, the outcomes and populations that were studied, and the strength of the experimental design that was used to evaluate. But once you get to these programs or strategies that you want to compare, there's a lot of information on each individual strategy's fact sheet that tells you a lot about some important other considerations besides the evidence that I'm going to talk about in a second. But things like, how much does this program cost? Who's the national trainer or provider? How much training is required? Who are the implementers? So it will help you think about, okay, beyond just, does this program have evidence of potentially changing the outcomes that I'm interested in? What are some of the other key considerations? One of the things you can look at is, how old is the published research? How old or how recent is the published research on these programs? And in some cases, you'll find that the programs that are on some of these registries, the research that landed the programs on the registries might be a decade or more old. And that's something to consider and keep in mind, but I wouldn't jump to the conclusion that simply because the research evidence on a particular strategy is dated, that means that it's no longer relevant or no longer effective. I mean, again, to use a medical metaphor, think about how long ago the evidence of the effectiveness of aspirin was established, and that is still a very, that evidence of the effectiveness of aspirin as a pain reliever and a medicine to reduce risk of heart attack. That evidence, even though that evidence was generated a long, long time ago, it is still relevant. So again, not to dismiss that completely, but it's something to thoughtfully consider, just as all of this evidence. So again, there's a number of these searchable registries, and we don't have time to go into each one and what the strengths and differences are, but it is a good exercise and a good use of your time just to visit each of these and just do some hypothetical or real searches. Put in some of the search variables and see what kind of programs that you generate. You can cast a wide net. You can put just a few things in. You could just say, I just want things that have evidence around drug use outcomes for adolescents, and not get any more specific than that. Or you can really drill down. You could say, I only want to see programs that have demonstrated outcomes on African American kids between the ages of 14 and 18, and that are school-based interventions, right? And that target these specific 2 risk factors. You can get that narrow and specific and focused in your search. And you can do both of those things and see, kind of see what it generates. So again, compare what each registry generates, and each time that you land on some specific programs, pull up the detailed description of one of those programs and look at all the information that's. So now, again, remember that beyond the research evidence, that really is the first thing that probably lands programs on these registries, and probably the key thing that decides whether a program is called evidence-based. Beyond that research evidence of being evaluated in an experimental study, there are also these 2 other very important considerations and types of evidence that should drive decisions about adopting prevention strategies: experiential evidence and contextual evidence. So I like to think of experiential evidence as like the farmer's almanac, right? People like the farmer's almanac isn't necessarily, that's not a bunch of evidence-based advice, but it's based on experiential evidence from generations of farmers who have just come to discover that certain things work and don't work in their farming and growing. Right? So the question is, what have others experienced with this strategy in the messy real world? That's really important form of evidence. And then contextual evidence gets into the measurable factors in the community or population that inform a match between needs and strategies. And those contextual evidence, those factors are likely to influence the implementation and success of a strategy as much as the research evidence. So contextual evidence can answer, does the community have the resources and capacity to implement the strategy effectively? What are the characteristics of the setting and population that you're going to be trying to reach with your strategy? Do you know that? Who will adopt and implement and sustain the strategy? If it's a school-based program, do you know that the school has the capacity and the willingness and the interest to adopt this strategy? And so contextual evidence is like, going back to my farmer's almanac metaphor, contextual evidence is like the fertile soil. Are you planting in a greenhouse, or are you dropping great seeds in the desert? Right? And if it's the desert is what you have to work with, but you have a really good seed, can you create a greenhouse in the desert? Can you build an infrastructure around your strategy to make sure that it's going to increase the likelihood that it's going to be effective? So across these 3 types of evidence, we have a formula to guide our decision making. Right? So evidence plus fit plus feasibility. These are the three choices that we want to think about in making decisions about adopting evidence-based strategies or adopting any strategy. And so we can think of this as a 3x3 table, for example. And if you're going through this exercise of comparing different potential programs or strategies, and you want a really structured way to go about that, you can actually use this 3x3 table and assign different point values to each cell and create a score, so that you know that you made an informed decision, that you're considering some of the most important things to consider. So communities and organizations can use this is a hexagon tool. So again, this will be in your resources, because this is something I think that you all should be familiar with and you can go to again and again. Communities can use this organization or can use this hexagon tool to better understand how a new or existing program or practice fits into an implementing site's current work and content. So like I said about creating those diagnostic profiles of community needs, this thoughtful decision-making process about potential options and among different prevention strategies is really where the prevention science meets prevention practice. So again, I encourage you to ask difficult questions about how did the current prevention strategies that exist in your community already, how were they selected and adopted? Were these questions considered? Is there a solid, consistent process for this kind of structured decision making? Because these decisions happen over and over and over again. Communities, schools, agencies, organizations, they're constantly having to make decisions about whether to adopt different programs or strategies to generate better outcomes. So is there a solid, consistent process for that kind of decision making? And is there room for improvement? So I think you'll agree that prevention is hard but critical work, and it requires support. And this goes back to my first message about the way we think about and the way we approach prevention as a profession that's grounded in a lot of good science and practice. So as a prevention professional, think about yourself as a Sherpa, right? You are a Sherpa helping a mountain climb Mount Everest, for example. You're an assistant in the decision-making process. Think of yourself as a prevention professional. Think of yourself as part of a decision support system. I hope that this broad overview of some of these key considerations in effective prevention practice has given you new ideas and sparked your curiosity about areas that you want to explore a little more deeply as you build your own, prevention professional competence. And so my final message, beyond all of that, is whatever you do in the name of prevention, evaluate. Always be assessing. Don't ever assume that our good intentions and our passion for promoting better outcomes for kids and families is going to be enough to achieve those good outcomes. Always be evaluating, because the evaluation is constantly telling us how we can strengthen it. So I'll stop there and leave us 10 or 15 minutes hopefully for some Q&A. I guess I'll keep sharing my slide because I've got a few more things I'm going to pop up, including the including the webinar evaluation at the very end. But Laura and Megan or others, are there themes of questions that came up in the chat that you want to share with me that maybe I can respond to?
I wouldn't say there are themes, but there are some questions, Brian, and one is a question that's looming on all of our minds, and that is related to funding and how that funding or loss of can potentially affect the outcomes and sustainability for some of these resources. Specifically, they say, what Considering the current and future funding, what pivots can you foresee might be occurring with the loss of funding to continue adding to blueprints? Currently it's in a dormant stage, but adding to it, but also its impact on other registries.
Yeah, so I mean, one of the challenges, and I'm taking that as maybe two different questions about funding. One is about funding and sustainment of these registries as a tool for supporting our prevention decision making. But was there also just kind of general questions about pivots in how we go about doing our prevention work based on the potential loss or reduction in funding? Was that a separate question, or?
I think it was just asking about what pivots might you foresee also occurring in the future, but that second piece as it relates to how we can potentially then use that information you're going to share and have that inform how we might pivot as prevention professionals. I think everyone would agree that could be helpful too. So yes, please address
Yeah, so, I mean, I think in terms of the registries, like I said, it's important to know that these registries themselves are subject to their own funding, and so that means that they come and go. And the Blueprints registry is currently, it has labeled itself as dormant because they are in between identifying funders to continue that registry. But I've spoken to the folks who developed and maintained that Blueprints registry, and they've told me that they don't anticipate that there's going to be any real dramatic urgent change. The website is going to stay up. They have been continuing to review new evidence about programs that were already included in the registry, even after they had lost their prior funding. So they might stop doing continuing reviews going forward here in 2025, but the registry itself will still be there. And they told me an interesting thing, that there are, it's important to keep in mind that there aren't hundreds of programs undergoing randomized controlled trials every year that they have to evaluate and make decisions about whether to add them to the registry. They only at most. I asked the director of that registry. I said, in the past 10 years, what's the most programs you've ever added to the registry in a single year? And she said 8. 8 is the most. In some years, it's only 1 or 2. So, so I would say that the registries, while they are up, even if they're not continuously updated, they're still a valuable source. And I hope one thing you all took away from the webinar today was the idea that the registries are not the final answer. It's one tool in your toolbox. It's a place to go and look to see whether a program or strategy has any evidence, whether it's ever been evaluated. Because the truth is that the vast majority of prevention strategies out there have never undergone any kind of rigorous evaluation. So we can't say with any confidence whether they do work or that they don't work. So again, that's why that final message of whatever you're doing, evaluate, so you know at least what's happening in your local community. In terms of that other question about, what's the future hold if prevention funding, especially federal prevention funding, is really going to be reduced, I would say that it makes it all the more important to make sure that we are making thoughtful, strategic decisions and setting priorities. If we have limited funds, if we have a huge reduction in funds, we can actually look at all the things that we're funding in the name of prevention, and we can prioritize which of those we think are either we know are generating good outcomes and we want to sustain them, or which ones we just have no idea what we're getting for our money. And obviously the low-hanging fruit is, are we doing any of those strategies that have been shown to be ineffective or even harmful? And are we spending resources that could be that are now much more limited and could be spent on better alternatives. Well, I'll leave it there. I want to leave time for more questions. I hope that was helpful.
We had a really great question come in about evaluation, and we encounter this a lot with ADAPT. A lot of communities struggle with not just starting evaluation, but evaluating to a point where they actually can measure effect, right? So engaging in a mechanism where they can measure effect in an evaluation approach that is useful to them. But then this question comes up often around, well, how long do I have to keep evaluating? So I'd like to read the question to you verbatim because it's phrased very well. If you create a program that is not evidence-based, but you follow evidence-based practices, and it continues to work for a community. So I'm going to interpret that as maybe it's got some core components that have an evidence base supporting them that have been integrated. How long do you have to keep collecting data for the program to be considered evidence-based?
Yeah, well, so again, if you go back to that CDC framework that I talked about, the first consideration in determining whether or not something is going to be called evidence-based is the quality and rigor of the evaluation design. And that's honestly, that's not something that local communities can't realistically do randomized controlled trials. And it's not an effective strategic use of resources to jump right to a randomized controlled trial unless you've already built a lot of good, solid, experiential and contextual evidence already. And then you can say, listen, we've been seeing great outcomes from this program in our local community or in a bunch of different local communities, even though we didn't find this program from an evidence-based registry, we developed it ourselves. We've been getting really good outcomes from it. We just, in the absence of a randomized controlled trial or other rigorous evaluation design, what we're missing is the ability to confidently attribute those outcomes to the specific intervention versus something else. But if you already have an accumulation of evidence, experiential and contextual evidence, pre-post-test evidence, for example, you could go to a researcher and say, listen, like partner with a university and say, can you help me evaluate this in a rigorous evaluation design? And that will also include questions about, well, how long would we have to follow these kids or these subjects in order to know that this program is actually demonstrating sustained effects?
Thank you. And one that came in just for clarity's sake, and this is probably a good one to end on. Can you briefly describe the distinction between evidence-based and evidence-informed?
Right. So I think generally again, it depends on who's saying the words. A lot of this language just kind of gets adopted and watered down and gets thrown around without a lot of careful thought to whether the thing means what the person is actually saying. So in my view, based on what I've covered in this webinar, I would say evidence-based means that it is a specific structured intervention that was specifically tested in a well-designed evaluation and demonstrated those outcomes that landed on that left side of the CDC figure that I described. Evidence-informed means if you go back to those prevention principles that I went through in the very beginning, and you could say, well, we developed a program that really lines up. It recognizes a lot of those things that we have learned from 50 years of prevention science, and it really lines up with the way prevention science collectively says we should be doing prevention work. So it is informed by the cumulative research, contextual and experiential evidence, but it's not a specific intervention that has been packaged and tested specifically. But again, that would place it at evidence informed is a place on the good end of that continuum of evidence. So it's much stronger than something that's just like, well, we came up with this on our own. We didn't really base it on anything but our gut punches about what causes the problem and what would help prevent it. So it looks like I think we have to stop there. I just wanted to share a few things, a few events to be aware of. And again, this is all going to, you don't have to write this down. It's all going to be in the resource supplement. But we've got some things coming up nationally across the country, and we hold a big prevention summit each year. That the next one is going to be on October 29th. Keep your eye out for that. Look at that. Go to the ADAPT website and sign up for our email list, etc.